Thanks everyone for joining. We will make a start. So welcome to New Insights on Disability and Health Equity. Thanks so much for joining us today. So I'd like to start with an acknowledgement to country. I'd like to acknowledge the traditional owners of the lands that we meet on today, the people of the Kulin Nation, and I'd like to pay my respects to the elders past and present. I'd also like to pay my respects to the lands that the people joining online are as well today. So I am Dennis Petrie. So I work at the Centre for Health Economics at Monash in the Monash Business School at Monash University. So I co-lead HEAD with Helen Dickinson. So a bit of housekeeping to start with. This meeting will be recorded and be put up online. So you can moderate what you say to some extent. But again, if you say anything that you don't want us to put online, make sure you let us know. We have live captions today. So if you activate captions by selecting Show CC on Zoom, you'll see the live captions. Alternatively, please check the chat function for the link for live captions in a separate window. For those with us today, there's a QR code for live captioning for those in the room. If you need help, there's an email address. So for the people online especially, if anything's not working, email that address. The speakers today, for the people online, if the screen is small, you can try and expand it by grabbing it or putting the spotlight on it. The other things, just wait. Okay, so just wait, emergency exits. So the lifts that people came in, for people in the room, if you go around the back of the lifts, there's the emergency exits. Today, so we've got a number of speakers. We're lucky enough to have a couple of Swedish colleagues from Lund University speaking today. So we've got Anne Alkren Schmidt, Mrs. Lu Yi, Dr. Yuan Jarl, and Professor Helen Dickinson. And then we also have a Q&A session, so we'll leave the questions and answers to the end of the session. But for those people online, put your questions in the Q&A online, and we'll come back to them at the end. And for those people in the room, make sure you remember what questions you want to ask different speakers, hold them in your head or write them on your phone, and we'll answer them at the end. And then for those people in the room, we've got light refreshments and networking at the end. Okay, so quickly, what is AHEAD? So AHEAD is a Centre of Research Excellence funded by the NHMRC for 5 years between 2024 and 2029. It's a collaboration between a number of different universities, Monash University, UNSW, the University of Melbourne, RMIT, the University of Sydney and ANU, along with a number of several international universities as well, including Lund University. And we have over 20 research affiliates as well, which is great because we're kind of expanding and trying to kind of bring together disability and inequity research, health and equity research in Australia. So AHEAD envisions a world where disability inclusive research generates new evidence-based solutions that dismantle barriers and open new opportunities to ensure health equity is an enduring reality for all people with disability. I will welcome Associate Professor Anne Alkren Schmidt. She's an Associate Professor in Disability and Public Health at Lund University, Sweden, worked at universities and federal agencies in the United States and Sweden. Most of her work relates to congenital or childhood onset disabilities such as cerebral palsy and spina bifida. She's currently the principal investigator of a 6-year research program entitled Moving On with CP. And so I'd like to welcome Anne to the floor.
So just move ahead, I guess, with this one.
Yeah.
All right. Well, thank you very much for the invite to present here today. I was told to start out by telling you what I look like. So I think I'm still sort of blondish. I used to be way more blonde, but I have blonde hair, blue eyes, I would say average height, and I'm wearing a cream-colored shirt. Yeah, so let's see here. I'm going the wrong way. So what I wanted to talk to you about today is basically just to give you some examples of some of the research that we're doing, because we do a lot of different types of research. And I think it's probably, having listened to you this morning, it's probably a little bit different than the type of research that you do. I am at the Faculty of Medicine, so I think to some extent what we do is more medically oriented, probably. But not completely. So we have, and it's pretty new, we're sort of setting it up, but we have what's called a Lund Disability Research Hub, and trying to put in, to kind of give you an idea of what we do, I would say that it falls into 3 different categories. So we do a lot of medically oriented stuff for research, but we also do public health and more socially related research. And then we have health economics, and we do this across the lifespan. So we tend to focus on congenital or early onset disabilities, as opposed to, let's say you have an accident or something when you're 45 and you become disabled in some way. That's not really what we focus on. We focus on disabilities that you're born with or you get at a very early age. And of course, you can look at this in different ways, and you can do research that's more non-diagnosis, more generic, which I think is what you guys do here a lot. And I used to do more in the US. But what we do, where I am now at Lund University, is more diagnosis specific for different reasons, including that we have specific registries that are focusing on specific types of disabilities. So the work that I do, we are expanding, but the work we've done so far has primarily been related to cerebral palsy. And just a reminder, if this is not really your field, cerebral palsy is caused by some type of brain injury, and it's going to occur. It can be in utero, and a lot of times it is. It can be at birth that something happens. It used to be the most common etiology, not so much anymore, at least not in Sweden, and sort of more, I don't know if developed is the right word, but it's not so much of a cause anymore in Europe and the US and probably here. But then we also do work related to spina bifida or myelomeningocele. Spina bifida covers a bunch of different diagnoses, and myelomeningocele is the most common and the most severe. So that tends to be the one diagnosis that we focus on. And what these 2 disabilities have in common is that they tend to be, or at least sometimes, they're lumped into sort of mobility disabilities. And you see this in Sweden, for instance, when you look at the habilitation centers where they receive a lot of the services. People kind of get put into different tracks. So if you, let's say you come and you have autism or you have ADHD, you tend to kind of go with the social worker and the psychologist. But if you have cerebral palsy or spina bifida, you tend to go with the PTs or the OTs, because it's more focused on mobility and spasticity and those kind of issues. I'm a psychologist by training, so I'm also very interested in cognition. And given that it is a brain injury that's driving the cerebral palsy, even though in order to get the diagnosis, you have to have, your mobility has to be affected, otherwise you don't get the diagnosis. And also with spina bifida, when you have myelomeningocele, you tend to also have hydrocephalus, and that can come with some concerns related to cognition. So what we have done, basically a definition, and this is the one from the APA in the US. So basically cognition includes really anything, knowing and awareness, such as perceiving, conceiving, remembering, reasoning, judging, imagining, and problem solving. So it's basically the entire kitchen sink. What I want to point out, at least the work that we do at the moment, when it comes to cerebral palsy, which is what I will be focusing on today, there is quite a big distinction between intellectual disability and specific cognitive difficulties. And I mean, this is not news to you. If you have a diagnosis of intellectual disability, it's, basically it has to happen from birth or early on. You have to generally you would have done some sort of neurocognitive testing where you would have probably done some sort of assessment looking at IQ, and you would have a cut point 70 or below. And then very importantly, you would also have to have difficulties in adaptive behaviors or basically independent living. Specific cognitive difficulties is different because you can have high IQ scores, and I'm just kind of focusing on IQ scores at the moment here. But you can have very significant issues in specific areas. And then you can have strength in other areas. So when you're looking at specific cognitive challenges, it tends to be an uneven profile, if you will. And this in cerebral palsy, I would say, gets overlooked quite a bit. It's clear often if you have intellectual disability, but the kids that have specific cognitive difficulties, they get overlooked for different reasons. One being that the focus is more on mobility and spasticity and all those other things, because it's a pretty complex disability. So just keep that in mind, that it's not necessarily the same. So for those of you who are here this morning, this is probably news to you not news to you at this point. In Sweden, since 1994, down in the southern part of Sweden, there was a registry and a follow-up program created that is basically, it was population-based in 2 healthcare regions down in 1994. 2007, it went national. So basically, when it started, it was only children, but now it's lifespan. So adults are also part of CPUP. But it's a really nice setup to make sure that kids. What happened was in the beginning that kids would come sort of after the fact. It started more from an orthopedic point of view. So they would come with really painful hip dislocations after they had their hips dislocated. And it wasn't a whole lot you could do. So the whole premise here was that if we keep following people over time and we collect systematic data over time, we can see early on when there's a decline, and we can go in and we can be proactive. So that's how this started. So it's been going on forever. And started, like I said, from more of an orthopedic point of view. But over the years, more and more disciplines have been included. And one of the latest disciplines to be included is a psychologist. And I'm not doing it anymore, but I used to be in charge of the cognition piece of this for CPUP. But since 1 year back, I'm not doing that anymore. But basically what we have, and this we do in Sweden and they do it in Norway, I should say. So we developed a protocol because we want to make sure that kids with cerebral palsy, we do the same for spina bifida, but that they actually are offered neurocognitive assessments, because we know it's an issue that gets kind of just sort of so many other things going on a lot of times. So it kind of gets put to the side. This is an older version because at this point we're also having a protocol for adults. But basically what we're asking is that the habilitation services offer the families to do before the kids start school, which is basically 5 or 6, that they're offered to do a neuropsychological eval. And also when they go from middle school to junior high, because those are transition times and it's stressful enough as it is. So if there are issues, it would be good to know that sort of coming in. I don't know how much you know about cerebral palsy, but there are different ways of sort of measuring gross motor function and manual abilities and all those kind of things. So the way it's set up, it's based on how severely affected your mobility is, and it's also based on age. And we recommend that there is a general cognitive functioning test, visual motor integration, and also executive functioning at a minimum. So I just wanted to give you some examples. I was asked to kind of tie this into labor markets and things. And I can't really do that with the studies that we've done, but I can tell you what we have done. We have started, and this is a paper that is incredibly straightforward, and it took forever to write. There's nothing complicated about the analysis or anything. It's basically descriptive. But it took forever because we were pulling data from different sources and a lot of data management. But we published it in Child Neuropsychology last year. And we wanted to just take a look. And this is really because of some of the issues that we know are concerns in our population with kids with cerebral palsy. We wanted to see how many psychologists reported that they used interpreters and AAC communications when they did the testing, which is a little bit controversial, and if the assessments were adapted. I'm not going to talk about that today. We also wanted to know if there were specific clinical characteristics associated with who was actually doing the assessments, or if it was across the board, which is what we recommend. And then what I kind of just want to briefly to show you today is we took the Wechsler scales, which is one of the most common IQ tests available, and we just broke it down descriptively by sex subtype, gross motor function, manual abilities, communication level, and epilepsy status. So this was a cross-sectional registry study, and we used CPUP data, which I just told you about. But there used to be another registry also that was only, I think, in 4 of the 21 healthcare regions. But they did a very similar protocol, and they started before CPUP. So we also pulled data from their registry because we don't have a whole bunch of data. It's not that common that you get those whole batteries. So we pulled data from CPUP, and the other one is called HubQ. So when we took the data from CPUP, we had 514 who did not necessarily the whole assessment that we recommend, but they did something and registered it into CPUP, into CPCOG. And we had 319 kids with cerebral palsy who had where we could actually calculate the full scale IQ. And from HubQ, which was only 4 regions then, we had 218 kids and 164 where we could calculate a full scale IQ. I'm sorry, I keep looking over here, but I have to see what I'm talking about here. So yeah. So just very briefly, the Wechsler scale, another reason it was kind of complicated is there are different Wechsler scales based on age. So for the really tiny kiddos, we do the WIPSI, and then there are different editions based on the year. So we had WIPSI for the young ones, and we had the 3rd edition and the 4th edition. For the older kids, we had the WISC, but also here we had different editions. So 4th and 5th edition. The way it's set up, I think you all know that it's like an average of 100, standard deviation of 15. But it's basically made up of a bunch of different subtests, and not all of these go into all the tests, but then you end up with different indices. And what I wanted to show you here is verbal comprehension, performance IQ, and a full scale IQ. Okay, so here what we did, this is looking at verbal intelligence. So the subtests that load into verbal intelligence are combined here. And if you look real fast at just the average scores, you can see that they're a little bit lower than sort of the typical population, if you want to call it that. And you can also see that it kind of, we broke it down by sex, subtype. GMFCS is the gross motor function, MAX is the hand function, and CFCS is the communication. So it is a bit lower, and there's basically a gradient based on what level you're at. But what's interesting, and what we kind of figured would be the case, is if you look at the range, it goes all the way from 40, I think, maybe 45 here. 40 is the lowest you basically can get, up to 137, which is getting close to gifted. And it looks the same way when you look at performance. Now, this is a little bit tricky when it comes to CP, because performance kind of requires you to be pretty fast and be able to manipulate with your fingers, which not all kids can do. So it's a little bit misleading. But we see the same thing here. Looking at the range, it goes from 40 to 153, which is definitely gifted. And we see the same thing then with the full scale IQ. So the take-home point here is that it is incredibly important to offer, in our opinion, to offer all families the ability to actually have the kids tested, because you don't always, like we have kids who people have thought really or almost had an intellectual disability that had very specific strengths that nobody really knew because they couldn't really communicate very well. But when you do those kind of more intensive testing, you can pick up on those kind of things, and you can work with the strengths, and you can try to work around the limitations. Just real fast, because I'm probably running over, which I tend to do. The whole thing about adapted assessment, it is a bit tricky because the tests really aren't made for kids with problems communicating or kids who have problems with fine motor skills. So we did see that in the cases where the assessment were adapted, it tends to be associated with lower scores. We also see a big effect on MAX, which is the manual ability, which in my mind, and not just in my mind, it's more a reflection of the test than it is maybe the kid's performance IQ. And then I wanted to give you an example of some of the work Johan and I have done. We wanted to look at school outcomes in kids with CP. This paper actually was published before the one I just talked about. So here we basically wanted to compare kids and adolescents with cerebral palsy to a comparison group that were matched 5-to-1 on age, gender, or sex, and municipality. And then we also wanted to not just compare it with sort of the comparison group, but also to look at specific disability factors. So again, those of you who were here this morning, Johan kind of talked about this, but not all of you were. So basically, we have this big database in Sweden where we have identified all the individuals for certain years with a diagnosis of cerebral palsy or spina bifida or myelomeningocele. And then we have pulled data from a bunch of different registries, including the registries where data on school achievement is available. We also have data on parents, so we can sort of get a sense of SES, but it's not perfect. And so basically data pulled from a number of different registries, including CPUP, because that's where we have more of the disability specific variables. So the way we define school achievement in this case, we had 5 different ways of looking at it, and some of these are conditioned on each other. So when, in order to look at the high school, you have to have basically gone through junior high first, and so on and so forth. But basically, if they received final grades in compulsory school, and that's up until 9th grade in Sweden, grade scores given, I guess this is, I don't know what you use here, but it would be like the GPA in the US kind of thing. It goes from 0 to 320. If they fulfilled the basic requirement to attend secondary school, if they actually attended secondary school or high school the final year, and if they fulfilled the basic requirements to attend university. And we'll get right into it. This here is not anything super surprising when you look at the top part. We already knew that we have more kids in Sweden with cerebral palsy and spina bifida who are either born somewhere else or have parents who are born abroad. It's not surprising that intellectual disability is higher in the group with cerebral palsy than in the comparison group here. And then what we wanted to look at then at the bottom here, you will see that looking at compulsory schools, so the younger ones, there is, for all of these, there's quite a substantial difference when it comes to receiving final grades, those are percentages. And then we have the mean scores for I'm going to say GPA because I don't know what it's called. And then same thing for if they fulfill the basic requirements to attend secondary school. And then for the older kids in high school, you see the same thing, that there's quite a substantial difference in terms of percentage who attended secondary school and who fulfilled the requirements for university. So basically, adolescents with cerebral palsy, and this is across the board, so some have really mild cerebral palsy and some have very severe. There's substantial reduction in school outcomes compared to matched controls of, similar ages. Of course, there's a big difference, like I said from the beginning, which is, we all know, intellectual disability. But what we found was, I'm wondering if I'm missing a slide. Go back here. Yeah. Okay. What I didn't mention this here, but if you see here across the top, CFCS, that is the communication. So now you've gross motor function, you've hand function, and your CFCS, your communication, is very highly correlated. But what really stood out in this analysis was that what was really on top of intellectual disability, which you would expect, was really driving sort of the difficulties that seem to be showing in our data is the communication level. You can see there's quite a big gap. So if you have CFCS level 1, you have sort of a better communication, if you will. Whereas CFCS level 5, it's more difficult for the person to communicate. And there's quite a big gap here. So yeah. So going back to this, so the inability to communicate effectively really seems to be a driving force here in terms of grades and getting ready for university and things like that. So our kind of take-home message from the paper was that we really need to take a good look at what kind of communication systems those kids and adolescents have, and if they're used appropriately. And I kind of put difficulties with communication does not equal intellectual difficulties or disability. And it's just really from more anecdotal that I've heard and I've seen a lot of people who kind of make the assumption if you have a little bit of a hard time talking, people will assume it's the same if you have a dialect and you go to different countries and they start talking like this or very loudly because they assume almost that you wouldn't really understand. And maybe it's different when it's a different language, but there are a lot of assumptions being made if you don't communicate effectively that people will make, even if they don't mean anything bad, there are assumptions made. So I think we have some work to do with special ed teachers and teachers in general. And then we didn't really, in this last paper now, looking at school achievement, we didn't get into those specific cognitive challenges that I talked about in the first paper. But I'm pretty sure, and maybe we can, it would be a small sample, but maybe we could look at that because I think a lot of the issues we're seeing in the kids who don't have intellectual disabilities, I think might be really related to those specific cognitive challenges and executive functioning issues and things like that. So I think that's something we can, and I'm looking at you, Johan, because you get to do the analysis. So we could really dig into that because I think that's a big concern. So really a broad range when it comes to cognitive functioning. And you really need, and I know that's being pushed in Australia too, because I do some work with the University of Sydney in cerebral palsy, and they're pushing it too. I didn't mention too much, but basically what we're seeing, which is what we were suspecting, and it is that the kids who have the most issues, physical issues, are the ones who don't get assessed. Could be that the parents say, no, we have enough to deal with, and that's, you know, we're busy enough or whatever. But I do think that it is more an insecurity from the psychologists, because I've spoken to basically all the psychologists who do this, and they're a little bit hesitant because it's difficult. Like you have this very standardized test, and you have to really do it by the book. And then you have a kid come in who might need an interpreter, who might need assistive technology, and they're not comfortable doing it. And the tests aren't made for this. So I think it might be that they were like, okay, we're just going to leave this one alone. They do a better job in Norway, actually, because they have some really highly trained neuropsychologists. But there is an inequity, definitely, who gets tested. And communication is very significant when it comes to school achievement on top of an intellectual disability. All right, thank you so much.
Thanks, Anne. I'd like to welcome next Lu Yi to present to us some. So Lu is a graduate researcher and research assistant in the Disability Health Unit at the University of Melbourne, and her research explores how social factors contribute to mental health inequalities for people with disability. Lu has a strong interest in applying advanced epidemiological methods and statistical methods to the analysis of longitudinal surveys. So welcome, Lu.
Hi, everyone. It's been a great honor to present today. My name is Lu. I'm a Chinese woman in my 20s with long black hair. Today, I'm wearing black t-shirt and blue jeans. I'll be presenting our work on trends in employment inequalities for people with and without disability in Australia from 2003 to 2023. Just as a brief background of this study, there's a big program of work happening within AHEAD, and one of the 4 stream focuses on employment. So we decided to do this work to provide better evidence of employment outcomes for people with disability compared to people without disability. I would like to acknowledge my supervisors, Glenda and Zoe, for their guidance and contribution to this work, and thank the funders for supporting this research. So what we know is people with disability experience substantial inequalities in employment compared to people without disability. And the United Nations reports that working-aged adults with disability are more than twice as likely to be unemployed compared to people without disability. These employment inequalities are strongly associated with poor mental health outcomes for people with disability. And importantly, these inequalities are likely to be influenced by age, sex, or gender, and type of disability. To promote inclusive employment and support participation in labor market for people with disability, Australia has implemented a series of national policies and programs over the past 2 decades, including the National Disability Strategy, the Disability Employment Services, and the NDIS. However, what we want to know is whether these policy efforts have reduced employment inequalities over time for people with disability. To address this knowledge gap, this study addressed 2 main research questions. The first one is, have inequalities in employment status between working-aged adults aged 20 to 64 years with and without disability in Australia changed between 2003 and 2023? And the second one is, do trends in employment inequalities vary by age, sex, and type of disability? So for the analysis, we use data from the Household Income and Labor Dynamics in Australia survey, which is a nationally representative longitudinal study conducted annually since 2001. We use data from wave 3 to wave 23, covering year 2003 to 2023. Our analytic sample included approximately 27,000 participants aged 20 to 64 years across waves, and the prevalence of disability remained relatively stable at around 23%. In HILDA, disability was defined as a long-term health condition, impairment, and disability, or disability that restricts everyday activities and has lasted or is likely to last for 6 months or more. Employment status was based on the activities in the previous 4 weeks of the interview and was categorized into 3 groups: employed, unemployed, and not in the labor force, or NEOF. Employed refers to engagement in any economic activities, including employees, employers, self-employed individuals, contributing family workers, etc. And unemployed refers to those not in paid employment, but actively seeking for work and available to start work. NEOF refers to those neither employed nor unemployed, including those seeking work but not available to start. This slide shows the analytic strategy we used. Because people with disability are likely to be older than people without disability, we applied direct age standardization using the age distribution of people with disability in wave 23 as the reference population. This allowed both groups to have comparable age distribution across waves. And for each wave, we estimated population-weighted prevalences as well as absolute and relative inequalities with their 95% confidence intervals. We measured both absolute and relative inequalities because they capture different aspects of inequalities. The absolute inequality captured the actual size of the gap and were calculated as the difference in the prevalence between people with and without disability, while the relative inequality shows how unequal the chances are and were calculated as the ratio of the prevalence between 2 groups. So by looking at both gives us a more complete and accurate picture of whether inequalities are truly improving over time. Changes in prevalences and inequalities over time are determined by non-overlapping 95% confidence intervals between the first and final years, which is year 2003 and 2023. To further examine whether employment inequalities differ across population groups, we conducted a series of subgroup analyses. Specifically, we repeated the analysis for the 3 employment outcomes across different age groups, including 20 to 34, 35 to 49, and 50 to 64 years, as well as between males and females. In addition, we examined inequalities by 6 types of disability, including sensory or speech, physical, intellectual or learning, psychological disability, brain injury or stroke, and other or not specified type of disability. However, due to the relatively small sample size for the unemployed group, we only disaggregate the employed and NIOF outcome for this disability type analysis. And due to the timing of the presentation, I'm not presenting the results of age group and sex today. I will briefly talk about some interesting patterns at the end, and the detailed results will be in the paper. I'm very happy to talk to anyone who are interested in this afterwards. This slide shows the prevalences of employment status over time by disability status. And thanks so much, Glenda, for making this beautiful graph. I'll firstly talk about the differences in prevalences between people with and without disability, and then trends of prevalences over time by comparing the 95% confidence interval between 2003 and 2023. The x-axis of the graph shows the year from 2003 to 2023, and the y-axis represents prevalence from 0 to 100%. The solid line represents people without disability, and the dotted line represents people with disability. The shaded ribbon indicate the 95% confidence intervals. When we look at differences in the prevalence between 2 groups across all waves, people with disability consistently had lower employment prevalences and higher prevalences of unemployment and NIOF compared to people without disability. For the trends over time, the non-overlapping 95% confidence intervals for employment between 2003 and 2023 showed that employment prevalences increased over time for both groups. In contrast, the non-overlapping 95% confidence intervals shows the overlapping confidence intervals shows the prevalence of unemployment did not change for both groups over time. And the prevalence of NIOF decreased over time for both groups given the non-overlapping 95% confidence intervals. This figure shows the absolute inequalities in employment by disability status over time. The y-axis represents absolute inequality in percentage points, where 0 indicates no difference between 2 groups. I'll firstly talk about the size of the inequalities experienced by people with disability, then the trends of these inequalities. We can see negative values for employment due to the lower employment prevalences among people with disability. People with disability experienced large absolute inequalities across all waves. They had approximately 23 to 31 percentage points lower employment compared to people without disability. The orange line shows the absolute inequalities in unemployment were small but persistent, generally around 1 to 3.5 percentage points higher. The purple line shows the absolute inequalities in NIOF were substantial, around 20 to 28 percentage points higher for people with disability. And the overlapping confidence intervals between 2003 and 2023 shows that these absolute inequalities did not change over time for people with disability. This figure shows the relative inequalities in employment over time. The y-axis shows the relative inequality ratio with a horizontal reference line at 1 indicating no difference, no inequality. So from the green line, we can see that relative inequalities in employment remain stable over time at around 0.6 to 0.7, meaning that people with disability were about 30 to 40% less likely to be employed compared to people without disability. And the relative inequalities in unemployment, which is the orange line, shows that the relative inequality remained stable, and people with disability were about 1.4 to 2.7 times more likely to be unemployed across the 21 years. However, relative inequalities in New York widened over time, increasing from around 2 times higher in 2003 to around 2.6 times higher in 2023. This slide shows inequalities in employment and NEOF across 6 disability groups. I know these figures are really small, but don't worry about reading them. The key patterns I'm trying to highlight here is overall, both absolute and relative inequalities in employment remain large and relatively stable for most disability groups over time. One exception was observed for people with psychological disability, where relative inequalities in employment showed some improvement from 0.3 in 2003 to 0.5 in 2023. However, this still indicates a very large inequality, as people with psychological disability are 50% less likely to be employed compared to people without disability. In addition, in the purple boxes, widened relative inequalities in NEOF were observed for several groups, including people with intellectual or learning disability, physical disability, brain injury, or stroke. And across all analyses, a consistent pattern emerged. People with intellectual or learning disability, brain injury or stroke, and psychological disability experienced the greatest absolute and relative inequalities in both employment and not in the labor force compared to other disability groups. In summary, people with disability experienced persistent and substantial inequalities in employment outcomes from 2003 to 2023. Neither absolute nor relative inequalities in employment showed improvement, and relative inequalities in NEOF widened over time. The greatest relative inequalities in employment were observed among older working-aged adults with disability, people with intellectual or learning disability, brain injury or stroke, and psychological disability. We know that there's been huge amount of investment and a lot of money has gone in employment as a priority area across multiple reforms, policies, and strategies. However, we did not see change over time despite that big investment. So strengthening monitoring, accountability, and evaluation of disability employment policies will be essential to improve employment outcomes and reduce long-term inequalities. Sorry. Thank you.
Thanks so much, Lou. So next we have Dr. Johan Jarl. So he's a health economist at Lund University, extensive experience in economic evaluations, also registry-based analysis, studying the consequences of disease and treatment. He has a particular interest in early onset disabilities and individual and family outcomes, for example, in terms of labour market productivity and family formation, which I think he's going to be presenting partly on today. And so he also looks at health and social interventions, how they can improve health, societal participation, and quality of life. His work focuses on the health economic aspects of disability, with a particular interest in cost-effectiveness analysis and broad societal consequences. So the floor is yours.
Thank you for having me. Almost start blushing when I hear someone else talking about what I've written about myself. But yeah. Okay, so my name is Johan Jarl. I'm a Swedish middle-aged man, closing in on 50. That because that's what I am and that's what I look like. To top things off, I have a bright blue shirt to really drive the point home. But anyway, enough about me. I'm going to talk today about research we're doing on how parents of children, how parents fare when they have a child with cerebral palsy. So the title of this presentation, Shared Challenges, Different Paths, How Early Onset Disability Affects Mothers and Fathers Differently. No, I'm trying to handle two computers here. So this is not only my work. Derek Asselman at Aarhus University is doing a lot of the heavy lifting and is well deserved to be mentioned, credited. It's also together with Hjördis Haraldsdottir and Tina Lofey Eskilsdottir at University of Iceland, and of course my collaborators at Lund University, and as you met, and Gunnar Henriklund. So the background again. About 6% of children born every year is born with a congenital disability worldwide. Now, we would expect the parents to be affected by this. You could argue for this from several points of view. One thing is, of course, taking care of a child is something that affects all parents. This is in the economic literature often referred to as a child penalty. When you get a child, you invest, you put resources and time into the care of the child, and therefore you're not working, your income falls, etc. You could argue then if you have a child that requires more care, more support, that would exacerbate that child penalty. It could also be that you respond to this as either leaving the workforce or having prolonged period of times not being in the workforce, reducing the chances for promotion, etc. You could also, as some would argue in Golden, for example, is that you would rather switch type of work. You would switch towards work and that would give you the flexibility, for example, to take time off, to not be present, to work from home. These are characteristics of work that is generally associated with, for example, lower pay. But you could make the other argument as well. If you have a child with higher needs, it requires more effort from you in terms of getting those resources in. So Becker, for example, would argue that this could lead to that you actually increase your labor market activities, that you work more. That in itself, working more and also giving that extra care and support to a child with needs could also influence your health, increase stress or physical and mental fatigue. And that kind of strain that this puts on the family unit could potentially affect family formation, likelihood of divorce or having additional children. And if divorced or if single, does having a child with a disability affect your chances of finding a new partner? There could be many different types of mechanisms. Things that we discuss in our papers here is, for example, reduced time for social interactions. You might not get out as much. Increased reluctance from prospective partners because of that share of care that you would be expected to partake in as a new partner. Again, Becker offers an alternative view here, and that's it, that you would be more likely to repartner because you do need to get that extra support. You do need to pool more resources into this into the family, so to speak. So, but this is of course very empirical research. So we're going to see which way does this go. But first, why would we look at this? Well, one thing is, of course, that the well-being of parents is of interest. They are part of society, and we're generally concerned about the well-being of people in our society. But you can also look at this from the child point of view. There is, we argue, risk of a double burden. If having a disability affects your parents when growing up, that could reduce or worsen your circumstances growing up. For example, reduce socioeconomic status, reduce income or income level of the family, etc. We know from research on general population that children growing up in more challenging situation, lower socioeconomic status, with parents who are sick, for example, will have, on average now, of course, lower probability of lifetime achievement. They will have lower education on average, lower income, less likely to be employed. So behind all this is a question about the negative consequences we see in terms of life outcomes among people with disabilities, and we're talking about cerebral palsy in specific here. How much of that is actually due to that the disability in itself affected your parents and the circumstances of your upbringing? But first thing first, cerebral palsy, Anne introduced it briefly. I'm not going to go into that much more, besides saying that it has a, yeah, I'm coming to that. But it's the most common childhood motor disability. And from a methodological point of view, and this is the only thing I'm going to say about the methods of these studies, but is that CP cannot be detected before birth. So there is no anticipatory behavior or selection. If we take, for example, spina bifida, this can be detected during the pregnancy, and a large share of those cases are terminated. This doesn't apply to CP. There is the likelihood that CP is uncorrelated with parental characteristics. So how likely is it that we can beforehand say who are more likely to have a child with CP? This has historically been certain characteristics that have been connected to this. This does not seem to apply anymore, at least not in Sweden and in Europe, Western Hemisphere. CP is very unlikely to be undiagnosed. So we observe all cases, and it's a relative common disability. So we get a large enough sample, but also that we can look at heterogeneity along several dimensions here. So we potentially argue, okay, we can't see that, but we can potentially consider the CP to be exogenous in the Swedish context. And why is that important? Well, we thereby argue that our results are causal, that what we see in our results is caused by having a child with CP. It's not caused by, for example, that parents who are of low socioeconomic status, low education, are more likely to have a child with CP, and therefore we see those effects. This is because the disability in itself. So what have we done? Well, we investigated if a child with CP affects parental mental health, labor market outcomes, and family formation. And this is, of course, not only one study. I'm aggregating several here. We've also investigated the impact, if the impact differs across different demographic, socioeconomic, disease-specific factors. So here today, I'm going to focus on gender or sex, maybe rather. Yeah, I'm not, again, wrong computer. I'm not going to say much about this. This is a Swedish study. We use Swedish registered data, big administrative data, where we're, as Anne said earlier, we can identify everyone with CP in Sweden. We're fairly confident about that. And we can identify the parents through our registers as well. which gives us the opportunity to do this kind of research. So what have we found? If we start with mental health, and defining mental health is a bit tricky. So here we have looked at what the results I'm going to present here is likelihood of being prescribed medication for anxiety or depression. We've also looked at actual diagnosis, etc. But we're going to focus here on the prescription. So if we look at any prescription for any reason, any mental health, we see here, okay, so we start with 2 years before and we put that to 0. And we are comparing between parents who have a child with CP to parents who have a child without CP. This without CP could be anything, right? It could be no health conditions. It could be something else. So it's important to remember. But this, what we see here, is that mothers after birth are more likely to have any prescription for poor mental health than mothers of children without CP. For fathers, however, we don't see any significant difference. If we look at antipsychotics, we see an effect for fathers. Fathers are more likely, fathers of children with CP are more likely to be prescribed antipsychotic medications after the birth of the child compared to fathers of children without CP. This is a mouthful every time. In terms of anxiety, we also see an effect for fathers. And this is a pretty large effect. It's a doubling, about 2 percentage points is a doubling of compared to fathers without children without CP. In terms of depression, however, we see an effect for mothers, but not for fathers. So when it comes to prescription for poor mental health, it seems to be some form of gendered, not effect on mental health necessarily, but in how it's prescribed and how it's diagnosed. If we look at labor market instead, and I explain as we go, I think. This is a similar setup, and we see that after the birth of the child, the likelihood that mothers are working is reduced compared to mothers of children without CP, right? So this is not the child penalty. This is the additional penalty. I know some people react to when we economists call it a child penalty. Excuse me to keep saying this, but it's engraved in my brain, unfortunately. But we don't see any effect for fathers. Now, for mothers, the effect disappears. The negative effect disappears after in terms of employment. But if we move on and look on earnings, and this is earnings conditioned on having an employment, but if we were to look at this unconditional, it would look basically the same. We see also for mothers here that there's a negative effect starting, which disappears, and then there's a positive effect for mothers of children with CP. Fathers, well, there's kind of a negative effect in the beginning, and then it disappears. So what is happening here? Well, that's a problem with administrative data register study. We don't know. We can only say that happens, right? But potentially, this is an artifact of the Swedish social insurance system. If you have a child with a disability, you can get personal assistance. So basically, you get funds to hire personal assistants. Now, those are in short supply in Sweden. So parents often step in and work as a personal assistant for their own children, or they take the night shift, they work normally during the day and then take the night shift as well. So our hypothesis is a word as a Swede I shouldn't say because I can't pronounce it, but is that this is due to the personal assistance, but we don't know yet. That's for future studies. In terms of disposable income, well, there's really no effect for fathers, but for mothers, having a child with cerebral palsy really increases disposable income compared to having a child without CP. This doesn't mean that they're richer necessarily, right? We don't know, we don't have their expenditure. We don't know their expenditures or what they have to pay. So this could be an artifact of them being compensated, for example, for adjusting the house or buying a new car or whatnot. Excuse me. But what's interesting here is really who is considered the primary caregiver here and who is actually receiving the benefits. Moving on to family formation, and yeah, I'll explain that as we go along as well. This is a bit more messy. So if we look at divorce, and we have studied this before as well, there's really no effect of having a child with cerebral palsy on the likelihood of the parents splitting up. And this is both divorce and separation, because cohabiting is quite common in Sweden. The likelihood of having additional children within that family unit, however, is reduced by, well, over 20%. So they're less likely to have additional children. That in itself could be a part of the explanation we saw on the increase in income for mothers. By not having an additional children, if other mothers have additional children, they will suffer, again, I'm trying to change my language here, they will experience the reduced in income from maternity leave, etc., a second time, which doesn't then happen if you're less likely to have an additional child. However, but if you're single or if you divorce or separate, we see that mothers of children with CP are much less likely to repartner, 23% about less likely, compared to mothers with a child without CP. But fathers are not affected. So they are repartner basically to the same extent as fathers of children without CP. Yeah, we skip that one and just go to the take-home message here. So having a child with disability, or rather cerebral palsy, but we like to draw the conclusion a bit further, do affect the parents, right? In terms of labor market outcomes, but also mental health and family formation. And this should we remember, in a context of a country with a quite comprehensive welfare system and considered family-friendly policies, at least in the past. So in countries without these kinds of welfare state mechanisms, you might expect the effects to be larger. So there are differences between the parents in terms of how their mental health is affected, but also then in terms of family formation, harder for mothers to repartner. And then this interesting outcome that mothers are actually having a higher income in the long run. Thank you.
Thanks, Johan. We'll move on to our last speaker, so Professor Helen Dickinson, who co-leads AHEAD with me, and so she makes it funner and better, because otherwise I wouldn't be. So she is Professor of Public Service Research in the Public Service Research Group at the School of Business, University of New South Wales, Canberra. Her expertise is in policy implementation and evaluation, with a particular interest in disability policies and programs. She's published lots of books, lots of journal articles, too many for you probably to read them all, but maybe you should try. And so, yes, she's very accomplished, and yes, we are lucky to have her.
Hi, everybody. So as a visual description, I'm a white woman in my mid-40s with shoulder-length brown hair. We're in Melbourne today, so I've got the Melbourne uniform of all black clothes on. And I'm going to talk today sort of really something we've been doing to engage with a broad range of stakeholders, and we think is a start of a kind of research process. I'm going to talk about it today, but I didn't do all of this on my own at all. There's a number of people in the room from AHEAD who were involved in this, but also another grant that a few of us sit across, which is called RAY, which is, I'll remember this, the Research Alliance for Youth Mental Health. And we came together to do some stuff around a recent policy change that's about to happen that relates to children in terms of the NDIS. And so as a bit of background, if you're not across this, late August of last year, the Minister for Health and Disability kind of made a bit of a surprise announcement that we were going to see the shift to the National Disability Insurance Scheme. I say surprise, it took a lot of people off guard. Even states and territories who were kind of quite involved in the delivery of this said they were surprised, although the federal government said, well, you shouldn't really have been very surprised about this because we'd had the independent review of the NDIS that came out in late 2023, I think that's right. One of the things that suggested was that we needed to develop a system of foundational support. So the critique of the NDIS review was that many of the issues that we find in the National Disability Insurance Scheme aren't necessarily because of what's happening in that scheme, it's because of services outside of that scheme and a kind of divestment of a number of different organisations and institutions around disability services. And so they'd said, well, what we need to do is kind of build up these foundational supports outside the scheme. It will take, it'll improve services and take some of the pressure off the scheme. And essentially, this is the first kind of foundational support that's going to be developed. So the proposal is that it moves children who are under 8, who are currently on the NDIS, well, they won't move those current ones on, but future children who have mild to moderate support needs and developmental delay or autism won't go into the NDIS in the future. They'll go into this scheme called Thriving Kids. After that was announced, there was a bit of tension between the states and territories and the federal governments as they kind of argued about this for a while and argued about, well, what will these services look like? What will be the scope of them? But recently, in the last month or so, they kind of came to an agreement around this. It got tied into debates around discussions around hospital funding. But now there's a commitment that there'll be $4 billion that will be allocated to this scheme that will be jointly funded between the federal government and states and territories. And they agreed to push back the original start date for the scheme as well, which was supposed to start about the middle of this year. It'll get pushed back a bit and changes will be made to access from, well, I can't see it there. Let me remember, 2028, I think is right. So there were lots of discussions around this reform that was happening, but a lot of the consultations that were happening with really short kind of timescales. So we sort of thought people are kind of talking to each other in their own sorts of spaces, but not necessarily kind of talking as part of a broader sort of group. So we wanted to bring people together who's in a number of areas where this would have kind of implications for. So, you know, across health organisations, educational organisations, peak bodies for allied health professionals who are involved in delivering some of this, some providers, and a bunch of other organisations all forgotten, but there's a list in there and in the final report that you can have a look that's on our website. And we wanted to talk to them about a couple of things. So we got about 35 people in there, and as I said, across AHEAD and RAY, there were 15 of us who were involved in facilitating those discussions. It was a 2-hour event. We had people coming at the start and we did a bit together, but then we went into small group discussions so we could really get into these questions. So what we wanted to know is really, like, what do we need to think about in terms of designing this sort of thing, and what evidence do we need to do that? What are some potential kind of unintended and maybe intended consequences of the reform, and you know, are the ways that we can think about mitigating some of the unintended and enhancing the intended? And what do we need to be able to implement it well? So what's going to make it successful, and how can we kind of monitor that? So I'm going to really quickly take you through some of the key headlines, but have a look at the report if you're interested as well. So people said to us, look, it's really important that it's a universal program. We know what it's supposed to do. So there's a big suspicion out in the community that some of this is driven by a need to save money for the NDIS. And people were saying, well, if that's your only measure of success, then that's not really a very good success measure. So we need a clearer sense of what that's supposed to do. And it needs to be universal in the sense it needs to be open to all kids who may have kind of differences and around learning. People said really clearly this shouldn't just be a national program where we decide it kind of centrally and then roll it out across the whole country. It needs to be really locally specific, because there's lots of things that are done in local areas that are really good at the moment that we can build on, and it needs to be built kind of up from a bottom up rather than being imposed from a kind of national government. People were really clear it needed to be co-designed, so that's with parents of kids, maybe it's with young people who have kind of recently transitioned out of that age group, but also all of the kind of different workforce professionals who would touch these kids, touch this kind of age group. So kind of early childhood education and care, schools, health organisations, community organisations, and that everybody needs to be involved in designing this in some way. A really key message was we need more time to do this. It can't happen. And as I said, the deadlines are being pushed back a bit, but also this real sense that it needs to be iterative. So it's not going to come in and just be developed and implemented and be successful or not. It needs to come in and then have time to bed in and to learn from that and iterate in terms of evaluation. People were really clear it needs multiple entry points. So there can't just be one entry point where you go like there is at the moment with the NDIS and get knocked back, that maybe you can go in through health services, you could be referred in from early childhood education and care, you might be referred in through schools, parents might be able to refer in, but also professionals who work with children could do that as well. So, make it easy to access, reduce some of those barriers, but also really focus on transition periods. And Anne, you were talking earlier about kind of transitions around schools and things like that. And we know that those transition periods can be really disruptive for everybody, but they're often kind of more significant for kids with disability. So there needs to be some extra kind of supports around those times. Really clear message that people wanted to avoid out-of-pocket costs. The more out-of-pocket costs that you have for parents, then the more barriers there are to access things, and particularly when we look into kind of groups who experience multiple kind of points of disadvantage. A really strong sense it needs to be trauma informed and neuroaffirming. A lot of the language that first came out around the announcement of it was seen to be particularly unhelpful. So initially the language was around children with mild to moderate autism or developmental delays, and that was, people felt that was really not helpful kind of language and very difficult to pick up in terms of, it means nothing in terms of diagnosis. But there was also a sense, particularly from the kind of autism community, that a lot of the debate around NDIS budget has highlighted kind of the number of people with autism who are in the scheme, and people were feeling like, well, we're kind of being blamed for this, right? And actually we're just seeking access to supports because our families and our kids need it, and this is really kind of detrimental language. Really big piece around building capacity of workforce and of families, and I'll say a bit more about that in a second. And so we also, well, what evidence do we need to kind of help design these reforms? And one of the real challenges is we don't have good evidence about who's in this cohort or what the level of their kind of needs are. We've got a bit of an idea from a few areas of data sets, but we also know there's a huge amount of unmet need out in the community as well. So there's really need to understand this group before you can start to kind of organise those services. And a huge challenge as well in the lack of joined up data. So we've got health data, we've got education data, we've got early childhood data, we might have some community data, but it's often not very linked up across those systems. So, they're not just separate services, they need to work together in practice if it's going to be successful. So we need to join up some of that data. And I said, again, this real sense that we need to be focusing on kind of the outcomes for children and not just what the costs are. And again, in the data we collect, we don't always collect very good data on outcomes. So we collect data around costs, but we don't necessarily have a sense of what those services deliver and the differences that they make to the lives of children or their families. In terms of intended and unintended consequences, people said, look, you know, in one way, there's a real opportunity here. We know that for this cohort in the NDIS, it doesn't always necessarily work well for this group. So at the moment where children access services, they're often taken out into individualized kind of clinic-based services. And, you know, it would be good if they could be brought closer to where children kind of live, learn and play. And, you know, the marketized system has not been great for a number of reasons. The minister suggested that there's a lot of, I think the language is problematic, over-servicing of children, but there's a sense that maybe resources aren't being allocated well. So people said, look, we know the current system doesn't work. And actually, if this was to work, and if it was to do some of the things that we would like, which is kind of make sure that early childhood and care, education and care settings are inclusive, that schools are inclusive, that communities are more inclusive, that would be really cool. So people said, maybe, you know, if we could get there, that would be a really good intended outcome of this reform. But a real sense that there's a huge risk that kids end up losing supports, and particularly linked to these issues around kind of budgets and stuff. And a sense that if, you know, there's a big, it comes with big consequences, right? So we know that early intervention is important. If we're going to reform a whole system around early intervention, is there a risk that those kids don't get appropriate supports now, which potentially then means they have greater kind of needs for downstream funding in the future? And with that in mind, you know, people are saying we need to be really clear about what the pathways are through the scheme. So if you get bottlenecks around particular things, whether it's around referrals into services or getting access to things, then you could potentially have those sorts of delays. This new scheme, I should have said this before, sorry, essentially moves what's now an individualized funding scheme into what sort of was there before in terms of it being more block funding for services. And the argument that a lot of parents have made is, you know, we went to the NDIS because that system didn't work for us. We didn't have choice. There were often long waiting lists. So definitely a sense that we need to not go back to that. So we've got issues over access and bottlenecks. Real concern about kind of eligibility. So some of this comes to the wording of the kind of levels of support needs, but also what happens for children, you know, there will be some children who will still be eligible for the NDIS. They won't necessarily just be put straight into Thriving Kids. But what happens to kids when they age out of Thriving Kids? So what are the eligibility criteria for the scheme going to look like? And there's quite a few concerns that the NDIS data shows continuously that while people who go in an early access pathway, and it was always, you know, set up so that people would be able to go in through that and get support for kids kind of early on. But the NDIS's data shows that once kids come in, they rarely leave the scheme. And so one of the concerns is a driver around this is, well, this is a way to cut off access into the scheme through that early kind of, so what's it going to look like? How are you going to, you know, if people still need support after the age of 8, how will they transition into the scheme? A real concern that, you know, if this reform was happening on its own, it would be a big reform, but it is not, right? So we've got multiple reforms going around early childhood education, care, schools, healthcare, and there's a workforce that are already kind of pretty stretched. So this is kind of creating a whole new set of issues for that workforce. So they've got to be really well supported to do this. Otherwise, it's not going to be successful. And you know, one of the things that quite a few people were clear about was the announcement already has caused a significant degree of stress and trauma for families and the kind of broader community. And so, you know, wanting to make sure any further kind of reform doesn't increase that level of stress. And we then sort of said, well, what does it need to be implemented well, and how will we know, how will we kind of monitor it? And it's all the things that you might kind of expect, given what I've talked about, strong partnerships that have got kind of local governance, not imposed top down, people kind of coming together and have some ability to shape what happens in their local areas. Good communication. So by that meaning, we really understand what this reform is about. We understand the different phases of it, that we've got good local communication as well. So everybody's in the right sort of place. And I spoke before about there's a real sense that, if it's a big bang, it'll be problematic. So to phase it in and to learn will be a really good way to go. One of the things a lot of people said was, even though it will be, they wanted it to be a local scheme, they did think there should be some national framework and maybe some sort of independent oversight body that would have a responsibility for making sure that there's some kind of national consistency. But again, stressing the real importance of having lived experience representation on that group, and needs some really careful thinking about workforce capability. And so that's both like in terms of the changes that are going to be made, but if a greater number of services are going to be wrapped around local areas, we know at the moment the kind of, well, for early childhood educators, they don't necessarily have to do any training around disability in their education processes, so don't necessarily have a huge amount of capability or understanding around this. Same in terms of teachers, they don't necessarily have to do any disability component in their training around teachers. So there's a huge amount of kind of uplift to do there. If we can have more responsibility kind of locally for some of that stuff, and it's not going to go through specialist services, there's a lot more understanding and skills development we need across those workforces. And in terms of evaluation, again, we need it to be co-designed. It needs to not just be kind of imposed. So meaningful kind of outcomes developed across a number of different sorts of groups. Again, you can see it was a really important thing that it's not just about kind of NDIS budget, but also not just about kind of clinical targets. It needs to be a broader sense of kind of well-being across both children and their parents. A real concern that we need to make sure we can track equity across this in a number of different ways. So, we know that generally when you do policy reforms, somehow middle-class families generally are sort of okay. But the more kind of intersectional characteristics that you kind of, that are embedded within families, then the more tricky that can be. And that's a really important part of evaluating this, to make sure it works in the same way for everybody. And so we published that report on like the same day or the next day or something. The advisory group there was an advisory group set up when the announcement was made, and they were tasked with coming up with a set of principles for the Thriving Kids scheme, and they published that like pretty much straight away. And there were a bunch of good things in there. Amongst others, but they did talk about it being led locally. So in terms of the budget, actually most of the budget, no, that's not right. So the 3.4 billion of the budget is going to go to states and territories, and they're going to have responsibility for spending that, and the federal government will just hold 600 million of that budget. So it will be led locally. They also talked about, yes, there needs to be multiple pathways in, and all the ways that I spoke about. Really importantly, there isn't a need for diagnosis. We know that often that really slows down processes if you've got a diagnosis, because that can take some time to go there. And there'll be no gap fees for allied health professionals, with the states and territories providing that. But as I said, still some real kind of concerns about, well, what's going to be different this time? If we're going to go back to this block funding thing, how are we going to design the system so we give ourselves different levers, so we don't end up with parents and children on waiting lists and being shunted around from one system to another, and making sure that people have a degree of choice in there where it's appropriate, but also that we've got kind of equally, good standards of services around and across areas. So, a real concern that, you don't end up with, really good services in more socioeconomically advantaged areas and kind of less so in others, as one example of that. And the bit it doesn't really managed to answer the report really talks about this workforce issue as being a really important one that we've got to kind of pay attention to, but it doesn't really have many answers. It talks about individual training quite a bit, so saying we'll make some online training available for teachers and things like that. But in research that we've been involved in, Sophie's been involved in as well, often parents say, well, you know, teachers are doing kind of the best they can. They don't really have great training, but they're really trying to do what they can. But often the school system and the broader system doesn't support them to do that. So, you know, it's very much talking about workforce capacity in terms of that individual skill development, rather than how do you kind of work the system so that you give people the ability to be able to respond to families in more effective ways. So what are we going to do next? I mean, the real crux of this is around implementation. You know, there can be lots of nice principles and all of that sort of stuff, but you know, when the rubber hits the road, that's where it gets kind of challenging. And so we're thinking about the degree to which we can capture some of this through AHEAD and other grants. I think one real possibility around AHEAD is thinking about the evaluation component of this. So the advisory report talks about evaluation being really important. It talks about it being iterative and about it being local and that people can learn from this, but there's not really a clear sense of what that looks like. So, you know, with combined with some of the comments about kind of the data for this cohort and maybe thinking about evaluation might be a place that we could put some of our skills around. But also very open to other discussions. If people have got ideas of how we can kind of be helpful in this space, how we can kind of leverage the research funding that we have for this grant and others to help feed into this process, then really happy to have that conversation. And I think that's it from me. Yeah. What's happening?
Great. I'll get the speakers to come up and sit down if you can. So now we've got some time for Q&A. We might start in the room if there's people with questions. If you can say where you're from and who you're directing the question to, that might be helpful. Anyone want to start us off?
Hi, this is Anna Ju from RMIT University. I've actually got questions for all of you, but I'll start with Lou, if that's okay. And then I'll give someone else a go. I won't ask all my questions, sorry. So Lou, thank you for your presentation. And I wanted to ask you a question about your conclusion about this kind of stable inequality, both absolute and relative, between those with and without disability over time. I noticed in one of your graphs that the employment levels for people with disability actually increased from 2018 to 2023. And that prompted me to think or to wonder whether or not attrition might be driving some of that, because we know that people with disabilities might be more susceptible to, say, COVID-19 effects. And so you might have more attrition either because they don't answer the survey or unfortunately they've died. And so I wonder whether or not you could look at differential attrition between people with and without disability, or even look at your analysis from 2003 to 2018 before COVID, so, or 2019, so you cut out the COVID effects.
Thank you so much for your question. And we actually didn't consider the COVID-19 effect, but we could look at the inequalities from 2003 to 2018 and exclude the inequalities, the effect of COVID-19 to the employment status for people with disability and the attrition. Thank you so much for this suggestion.
Other questions before we have to go back to Anna to ask more of her questions? We'll go to Corinne, and then do you have questions from people online, James? Yeah. Okay. We'll go to Corinne and then we might come.
Hello, I'm Corinna from University of Melbourne. My question was for, is it Jan? How do I say it? Johan, sorry if I'm saying that wrong. I just thought it was interesting on your event studies, particularly with prescription medicines, you were only going back. So I think your reference period was 2 years prior to birth, and then you only had 1 year prior, and I was wondering if you could talk a bit about that. And then the second comment I had was potentially if you could look at the earnings aspect, and you were talking about one of the things that might be happening is that women might not be having another kid. And I was wondering if you could then just make your control groups people who only have one birth, for example.
Yeah, thank you. Yes, we use 2 years before, but normally you would want to use the year before the event. But given that pregnancy starts before the event, we wanted to avoid that. So that's why we put it 2 years before. That was the only reason for that. We could go back further in terms of time backwards. I don't remember if we checked, but the data is there at least. We lose a bit of sample if we do it, but yeah. The second question was in terms of income.
Saying that you think one of the stories might be that people who have children with cerebral palsy might not have a second child. But I was wondering, could you just then make your comparison group people who don't have a second child?
So what we actually look at here, I never said that, is that we're looking at mothers because we can't observe the father's first child or first pregnancy. First childbirth. That for methodological reason, that solves some of the problems. What we could do is, as you say, well, the problem is if we're starting to control for things that happens after the event, that would be a bad control and risk bias. So it's statistically a bit more difficult, I would say, and that's why we didn't do it as now. I haven't thought much about it, how to try to disentangle this effect in a future study. We haven't done it now, at least. That's the short answer.
Great, thanks. James, a question online for either Helen or Anne, maybe, just to give them a turn.
Yes, I have one for Helen. So no diagnosis, no gap fees. As an economist, I'm always concerned with how we allocate those scarce resources towards high value activities for those that need them most. Is there a risk that these resources will be captured by certain groups?
That sounds like you.
Does.
Look, it's a tricky one, isn't it? And yes, I mean, so while it says no diagnosis, that's to access some of the services. But if you step up into terms of access to some allied health services, then there will be a kind of functional, some sort of functional impairment test. I don't know what it's going to look like at the moment, but there will be, although there's no diagnosis to get into the scheme as a whole. There might be to get into some parts of it. And look, I mean, we don't know, do we? I mean, this is a challenge. There's not enough detail in it yet to know about how you'll divert into those high impact stuff. And I think a real need for a lot more research evidence around that.
Great, thanks, Helen.
I have another one here. This one's for Anne. Very interesting research. My question is, where to from here? How do we find out which cerebral palsy kids need more support and what that support looks like? And how do we integrate it within schools, conduct assessments, and educate teachers on the extra needs that those kids with cerebral palsy need?
Yeah, that's a very good question. I think in terms of the first part is to really make sure that families have access to neuropsychologists, which in and of itself is an issue. At least in Sweden, a lot of neuropsychologists, like I said briefly, I think, spend a lot of time with kids with autism and ADHD. And they do assessments with kids with spina bifida and CP if they have time. Sort of, at least in a lot of places, it's like that. But it is a big issue with schools, because it doesn't matter if you have an assessment where you find all sorts of things if you don't sort of use that to actually do something about it. And we haven't up until now, because CPUP is very health oriented. It's sort of PTOT, speech language, but it's not really capturing school. So that's actually something that we want to look into and try to get into more, because that's basically where kids spend their time. And you know, you could be wasting a lot of time if you don't have the right supports and things like that. So it's a tricky question, but one of the things that we're going to try to do is to kind of, for me, it's a little bit of a new field to this sort of educational arena, but we're going to try to start attending more. I'm looking at you as if you asked a question, but to go to those kind of conferences and start networking a little bit more, because we kind of stuck in the same habilitation like the people we always work with. So I think we need to really reach out into more the special ed and education. And I sit on the board for the Spina Bifida CP Sweden organization. And one of the things that we're really trying to do is to bring in more educators and really try to have some strong leaders on our advisory board, because we have a lot of the other sort of spots filled, but we're struggling a little bit to kind of get the education in there, but that's what we're doing.
Great. Any last burning question from anybody? This is your last chance. No. Well, I'd like to thank so much the speakers. We have a small gift for them all. So for those people online, that brings us to the end of our session. So thanks so much for joining. The next slide. So thanks so much. One thing to note is we have a seed funding round open, so you can see on our website details of the seed funding, and so that's to try and kind of encourage new projects trying to get off the ground. So you can have a look at that and contact us if you have any questions. You can follow us on LinkedIn or look at our website, so where we keep our up-to-date information. Thanks so much. And for those people in the room, so one other thing, can we do evaluation? I'm lucky. I have to thank GOSDAY, because without GOSDAY, this thing doesn't happen. But if everyone can do an evaluation of today, that would be really good as well. So there's the QR code. So for those people online, thanks so much. And for those people in the room, after you do the survey, then we can go outside and get some food after the survey faster. But yeah, thanks so much.